Okay, thank you for the invitation. It's a pleasure to be here. I intend to give, initially I thought about giving 2 lectures on critical care medicine board review. I just realized there is a lot of material and sometimes compressing too much in one lecture might not be a good thing. So I'm thinking of maybe changing to 3 lectures on board review. And then I also wanted to give a couple of lectures on ultrasound. I know last year you guys had that with Bilal, and I think it's going to be a good thing for us to have some theoretical lectures on ultrasound, since we do a lot in the ICU. So this is something that I'm planning for you guys, okay? So today we're going to cover these topics here. So we'll start with lactic acidosis, hyponatremia, hypernatremia, drug poisoning, cyanide toxicity, carbon monoxide toxicity, methemoglobinemia, hypothermia. So starting off with lactic acidosis, so in order to generate lactic acidosis, pyruvate combines with NADH, and the pyruvate is generated mostly by anaerobic glycolysis. This is done mainly in the skeletal muscles. And lactate is reconverted back to pyruvate and consumed in the mitochondria. So this is an ongoing process where generation and consumption of lactate are kind of equivalent. And lactate can rise markedly with exercise when you have a seizure, but it's also rapidly consumed. And there are 4 main mechanisms that can generate lactic acidosis. The most common is tissue hypoxia. So lack of oxygen will lead to decreased mitochondrial oxidation. And that can come from either decreased oxygen delivery, but also from problems of microcirculation that happens in sepsis. Sometimes you are not really hypoxic, but still can develop lactic acidosis because you have problems with your microcirculation. And tissue hypoxia will occur when you have severe hypoxemia, anemia, shock, sepsis, carbon monoxide poisoning. The other mechanism is not as common, but it happens. It's aerobic glycolysis, through stimulation of the beta-2 adrenal receptor. So a lot of people are unaware that epinephrine or even albuterol can stimulate the beta-2 receptor and cause lactic acidosis. That can happen also with pheochromocytoma and heart failure. A third mechanism is impaired oxidative phosphorylation, and that occurs with medications. Antiretroviral therapy, metformin is famous for causing that. Propofol, salicylates, and toxic alcohols. And the 4th mechanism is actually impairment of pyruvate dehydrogenase activity, and that is caused by thiamine deficiency. So this is just a figure showing that through anaerobic glycolysis you create pyruvate, and then that combines with NADH to form lactate. And then this is the mechanism by which lactate is generated through stimulation of the beta-2 receptor. So that can be from epinephrine or albuterol and so on. So the clue for the diagnosis, of course, you're all aware of that, is increase in anion gap. However, you should know that normal anion gap is present in about half of the cases where you have a high lactate level. So the lactate can be measured in the arterial venous blood. And there is the higher lactate, the worse your prognosis. So this is very well demonstrated. But we don't know if lactate itself can cause damage, or it's just a signal that the physiology is altered. The management usually is treat the underlying cause that is causing lactic acidosis. But if the pH is less than 7.2, sometimes that can become an issue. A lot of times these patients become refractory to vasoactive drugs. So sometimes if the pH is less than 7.2, we'll give bicarbonate, although this is controversial. Bicarbonate can cause carbon dioxide accumulation and also a decrease in calcium level. And occasionally, we also do dialysis. Again, those are controversial treatments, but sometimes we have to do if the pH is very low. Mostly treats the underlying cause. So moving to hyponatremia. So defined as a serum sodium of less than 136, It's a very common water balance disorder. And the first step when you're dealing with someone with hyponatremia is to differentiate hypotonic versus non-hypotonic hyponatremia. So non-hypotonic hyponatremia can be pseudo-hyponatremia, a laboratory artifact, and that is caused by high protein, high triglyceride, high cholesterol. And non-hypotonic hyponatremia can also be caused by hyperglycemia, mannitol, and hypertonic radial contrast. So the first thing when you're dealing with someone with hyponatremia is try to rule out non-hypotonic hyponatremia. Also, it's very important to try to establish whether the hyponatremia is moderate versus severe less than 125, acute, less than 48 hours versus chronic, symptomatic versus asymptomatic, like we already said, hypotonic versus isotonic or hypertonic, and hypovolemic or volemic versus hypervolemic. So the most common cause of hyponatremia are SIDH, diuretic, polydipsia, adrenal insufficiency, hypovolemia, heart failure. But there are also some settings that can predispose hyponatremia, so the pause-op period, exercise, vigorous exercise, ecstasies, antipsychotic, in particular haloperidol, thiazide diuretics, and so on. So I think this is, it's a little busy, but I think this is very helpful, okay, this flowgram to help the management of hyponatremia. So the first step is to establish whether the patient is symptomatic from the hyponatremia. The patient is having seizure, altered mental status, in which case you're going to immediately treat the patient with hypertonic saline. We have to be very careful not to overtreat, and we're going to go from there. But that is the first step. Second step, you want to get the urine osmolality. And if the urine osmolality is low, less than 100, I like to talk about that during rounds. There are very few things that cause a low urine osmolality. So polydipsia, beerpotomania. So very few things. Because in all the causes of hyponatremia, you're going to have an increase in the ADH. And this increase in the ADH will lead to a high osmolality in the urine. Okay, so all the causes of hyponatremia are going to have an increase in antidiuretic hormone, which is going to lead to an increase in the urine osmolality. So getting a urine osmolality initially is a very important step as well. Then you're going to get a urine sodium. And if the urine sodium is low, it means that the effective volume to the kidney is decreased. If the effective volume to the kidney is decreased, either it's because the patient is hypovolemic, or the patient is actually hypervolemic, but again, the effective volume is down to the kidneys. If the patient is hypervolemic, that's going to be easy to pick up. Those are typically patients who have liver cirrhosis and they are edematous, or patients who have florid heart failure. If that's not the case and the urine sodium is low, most likely you're going to have a patient who is hypovolemic. Okay? If the urine sodium is high, then a lot of times this is going to be due to SIDH, okay? And it can be also from adrenal insufficiency and hypothyroidism. In the end, all from increased release of ADH. So this is important here. So if you have a rapid onset of acute hypernatremia or rapid correction of chronic hyponatremia, you're going to have osmotic demyelination. Okay. On the other hand, if you have a rapid onset of acute hyponatremia or rapid correction of chronic hypernatremia, you can have cerebral edema or oncal herniation. So the treatment for symptomatic hyponatremia is hypertonic saline. This is what is in the guidelines. So you're gonna give a bolus of sodium chloride 3%, 100 cc over 10 minutes times 3 as needed. For severe symptoms. If the symptoms are moderate, there is some recommendation about continuous infusion. I'll be a little concerned about giving continuous infusion of 3% sodium chlorides, particularly with the delay that you can have in obtaining sodium level. I still like to give the bolus here if needed. Okay? In regards to the treatment of chronic hyponatremia, it depends on the cause. If it is SIDH, you're going to do fluid restriction. Hypovolemic hyponatremia is going to be treated with normal saline or lactated ringer. Hypervolemic hyponatremia is usually treated with fluid restriction. So those are the situations where you're going to have a high risk of demyelination syndrome, which is something that we get very scared of and we want to avoid. So obviously, the lower your sodium to begin with, the higher the risk that you can, the higher the risk of developing demyelination syndrome with overcorrection. But also, if you have hypokalemia, alcoholism, malnutrition, liver disease, those are risk factors to develop demyelination syndrome. So be on top of that. And usually, you're going to target a correction of no more than 8 millimole per day, or per liter per day. So you don't want your sodium to go up by more than 8 over 24 hours. If your baseline serum sodium, so if you end up overcorrecting, what you're going to do, which happens very often, right? Sometimes because the patient overcorrects on their own. It's not like the patient just overcorrect on their own. But if that happens, so if your baseline serum sodium is more than 120, it's probably not needed to lower the sodium. But if the baseline serum sodium is less than 120, you're going to lower the sodium again, relower, either with hypotonic solution, or electrolyte-free water, or desmopressin.
Dr. Cavallazzi, that's in chronic hyponatremia, right?
Yes.
We can fix acute hyponatremia without concern for overcorrection.
Yeah, but a lot of times you're not completely sure whether it is acute versus chronic. If you have a massive overcorrection, even in acute hyponatremia, I would be worried, depending on the baseline serum sodium. But this is more for chronic hyponatremia. You're right. For acute hyponatremia, the risk of osmotic demyelination is not that high. So the risk is higher with chronic hyponatremia, so your urge to reload the sodium will be higher when you have chronic hyponatremia. So hypernatremia, it's so the serum concentration of sodium is controlled by water homeostasis, so thirst, arginine, vasopressin, and the kidneys. So hypernatremia represents a deficit of water. And this can be a secondary to a net water loss or hypertonic sodium gain. So if it is a net water loss, it can be pure water loss, so diabetes insipidus or unreplaced insensible losses, or it can be hypotonic fluid loss. So if that happens with loop diuretic, osmotic diuresis, vomiting, diarrhea, and burn. And so hypernatremia typically occurs in patients who are unable to get water. So that the typical patients that will develop hypernatremia, patients who have altered mental status, particularly patients who are in nursing homes, intubated patients, infants, and elderly. So when you develop hypernatremia, there are two types of adaptation. There's a rapid adaptation with accumulation of electrolytes, and there is a more chronic adaptation of accumulation of organic osmolytes. So if you overcorrect the hypernatremia, you are at risk of developing cerebral edema. This is something you want to avoid. So when you are going to manage hypernatremia, you want to address the underlying cause. Why is the patient developing hypernatremia? Is this diabetes insipidus? Is this a patient who is just not being offered water or being given water? You're going to correct the hypernatremia. And the target fall in serum sodium concentration is 10 millimole per liter per day. The preferred route to correct hypernatremia is oral, but if IV solution is used, then you should use a hypotonic fluid. This is from an article in the New England Journal of Medicine now, 20 years ago. And I thought this formula is very interesting. They don't always work, but it's something that you guys wanna be aware of. This formula will provide you the change in serum sodium that you're going to get once you give 1 liter of any of these solutions here. Okay? So you're going to give 1 liter of, 0.45 sodium chloride in water, and how much of that is going to change your serum sodium? That will depend on the sodium infusate, so in that case 77, the serum sodium, the total body water, which you can easily calculate, 0.5, 0.6 times weight, plus 1. So I thought this formula is interesting. I often use that to kind of try to understand how much of a change in the serum sodium I'm going to get with any hypotonic solution here. So we're going to move on to drug poisoning. So this is just showing that this is age-adjusted rate per 100,000 population of drug overdose deaths by state. Kentucky is one of the states that have a high rate of death by drug overdose. This is also an interesting graph. I don't know if you all can read here, but this is synthetic opioids. This is mostly fentanyl. So fentanyl is responsible for most deaths. And then, this is difficult to read here. So this is all the opioids. Okay, this is heroin. This is heroin. This is heroin, and this is cocaine. Okay, this is a little difficult to read here, but yes. So mostly opioids, and fentanyl is the most one, and then prescription opioids, and then you have heroin, and then you have cocaine. Those are the main causes of drug overdose death. So this is kind of useful to know your toxidromes. So when a patient comes with drug poisoning that you don't know the etiology, at least that can give you a direction as to what the patient may have ingested. So you have 4 main toxidromes. Anticholinergic, so you're going to have dilated pupils, dry mucous membrane, altered mental status. So the drugs that will cause an anticholinergic toxidrome will be tricyclic, atropine, antispasmodics, phenothiazine. And then you have the cholinergic toxidrome, which is going to be characterized by diarrhea, diaphoresis, bradycardia, constricted pupils, and most importantly, bronchorrhea. Okay, so these patients, the drugs that will cause the cholinergic toxidrome will be nicotine, carbamate, organophosphate, and so on. Opioid toxidrome, constricted pupils, depressed respiratory drive, that is the hallmark, so fentanyl, heroin, etc. And sympathicomimetic, dilated pupils, tachycardia, hypertension. Interestingly, the sympathicomimetic, the new drugs, bath salts, synthetic catinones, pseudoephedrine, they all can cause that, okay? So, one of the things that you might want to do when you're dealing with someone who has a drug overdose and you're not sure what is causing is to get the osmolar gap. So osmolality can be measured by osmotic osmometer, and osmolarity can be calculated. So you guys can calculate the osmolarity, and with that you can obtain the osmolar gap. So if there is an osmotic substance that you're not accounting for here, you're going to have a high osmolar gap, typically more than 10. If there is a substance that you're not accounting for here, typically the substance, if there is one, is going to be an alcohol. Those are the alcohols that cause elevated osmolar gap. Okay, so ethanol, isopropanol, methanol, ethylene glycol. Ethylene glycol is a common cause. This is found in antifreeze. It's a common cause of suicide attempt. We have seen a couple of cases. You want to calculate your anion gap, and there are a couple of things that can cause elevated anion gap. You are all aware of that. Methanol, ethylene glycol, salicylates, and so on. You want to be aware that there are drugs that block the cardiac potassium efflux channel, and those drugs are going to cause a QT interval prolongation. And there are drugs that block the cardiac fast sodium channels, and those drugs will cause a widening of the QRS. Now, 3% of the non-cardiac drugs can prolong the QT. So those are common drugs that can prolong the QT: antihistamines, antipsychotics, class 1A, 1C, and 3 antiarrhythmics, the fluoquinolones, the macrolides, and methadone. So those drugs can prolong the QT, and they can cause torsades de pointes, ventricular tachycardia, re-entry. So for those patients, it's very important to keep the electrolytes in the normal range. Make sure your magnesium is at a normal level. And whenever a patient comes with drug poisoning, make sure you get an EKG and you check that, okay? And drugs that block the cardiac sodium channel, the most common that we see with toxicity is tricyclic antidepressives. We see every month, basically, carbamazepine, also class 1 and 1C antiarrhythmics, cocaine, phenothiazine, propranolol, verapamil. And these drugs, they can cause sine wave pattern and ventral asystole, and they are treated with sodium bicarbonate. The tricyclics, they can also, as your KRS gets widened, you're at risk of developing seizures as well. In the setting of drug toxicity, if you have hyperthermia, you got to think of 3 syndromes here, okay? Serotonin syndrome, neuroleptic malignant syndrome, and malignant hyperthermia. So I'm going to talk briefly about each of these. So serotonin syndrome can be caused by either drug interaction, so monoamine oxidase inhibitor plus meperidine. It can be caused by SSRI as well. There are some antibiotics that can cause that, like linezolid. So you have to be aware of some drugs that can cause, mostly SSRI or drug interaction. So it is characterized when you develop serotonin syndrome by high temperature, altered mental status, rigidity, hyperreflex, and clonus. Those are the 2 physical examination findings that will point to this diagnosis that you got to pay attention to. Okay, so whenever you're examining your patient, look at the reflex, look for clonus. And the treatment is support, clinical support. If the patient is too altered, maybe the patient will require endotracheal intubation, IV fluids, but also you can give cyproheptadine. Now, neuroleptic malignant syndrome is typically caused by antipsychotics, so the dopamine receptor antagonists, but can also be caused by sudden withdrawal of dopamine agonists. The presentation is similar to serotonin syndrome, but not as much hyperreflexia here. They can have high fever, altered mental status, rigidity, and this is very similar to serotonin syndrome. They also have a lot of autonomic instability, elevated CPK. The treatment here is going to be bromocriptine, amantadine, and dantrolene. So those 2 conditions we see very often. Actually, serotonin syndrome, I think it's often missed, often overlooked. I think we see a lot, both in the hospital and in the ICU. Malignant hyperthermia, we don't see that as often ourselves. Probably the anesthesiologist might see that more often. But it's genetically susceptible individuals when they're exposed to depolarizing neuromuscular blocking agents or volatile general anesthesics. So basically here, the treatment again is removing the inciting agent, supportive care, and you can give dantrolene as well. So those are some of the antidotes that this list is far from being comprehensive, but obviously never forget to give acetylcysteine when you have Tylenol toxicity. For beta blocker, you can give glucagon, calcium vasopressor, insulin plus glucose, and then you can also give lipid emulsion therapy. You go on a stepwise approach. Same thing with calcium channel blocker. It's pretty much the same treatment. Opioids, naloxone, but you got to be careful because if the patient is intubated, so the main reason to give naloxone is to prevent a patient from developing full-blown respiratory failure. But if the patient is already on the ventilator, I don't see much benefit from that. Naloxone can cause a adrenergic surge, and then some patients can develop pulmonary edema when they receive naloxone. It's a life-saving drug, particularly in the field, but if the patient is already intubated, I don't see much of a benefit. I'm talking from an ICU perspective, okay? Methanol and ethylene glycol, there's fomepizole. Sometimes these patients will require dialysis. And there's more, but we're not going to go over. So I'm going to talk a little bit about cyanide toxicity. We have seen some cases in our ICU. So cyanide toxicity can occur from inhalation of cyanide-containing gas or dust-containing cyanide. This can occur in the industry. This can occur in combustion. Most patients with cyanide toxicity, they'll develop that from domestic fires. Okay, domestic fire. It can be skin absorption of cyanide-containing liquids. This is going to be in industry. It can be from ingestion if the patient is committing a suicide, or food, cassava, apricot seeds, bitter almonds. And obviously, IV sodium nitroprusside can cause that. So the cyanide actually impairs the phosphorylation, oxidative phosphorylation. So suddenly the cell is not able to use the oxygen anymore. Okay? And the symptoms, you have CNS symptoms such as headache, but it can go all the way to seizure and coma. It can cause bradycardia, hypotension, pulmonary edema. It can cause nausea, vomiting, renal failure, all types of symptoms. So you're going to suspect anybody who has been exposed to a fire, particularly indoor, and if this patient has annual gap metabolic acidosis, you're going to suspect that. If the lactic acid is high, if the venous oxygen saturation is high, because you're unable to use the oxygen because of impaired phosphorylation. So this is a tip for this. Though typically the cyanide concentration is not that useful, because you can have a cyanide level that is normal, and yet you have cyanide toxicity, so that is not that useful. So the main treatment for cyanide toxicity is hydroxycobalamin. Okay, you can also use other treatments such as nitrates and then thiosulfate. But the main treatment for cyanide toxicity is hydroxycobalamin. So moving to carbon monoxide toxicity, and sometimes they go together, cyanide and carbon monoxide toxicity. So again, smoke inhalation is the main cause. Malfunctional heating system, particularly in the wintertime, improperly vented fuel burning devices, motor vehicles in poorly ventilated areas. And this is interesting, I didn't know that, but hookah can cause that. It binds to the iron moiety, the carbon monoxide binds to the iron moiety, decreases the oxygen carrying capacity, and impairs the peripheral unloading of oxygen from hemoglobin. So it can cause acute neurological symptoms, it can cause myocardial injury, and also it can cause a delayed neuropsychiatric syndrome. So even after the patient gets discharged, and the patient can develop some mental impairments from that. So how you're going to diagnose this? So the standard pulse oximetry does not differentiate carboxyhemoglobin from oxyhemoglobin. So you have to get a co-oximetry. So you get the blood, arterial blood, and then you ask the respiratory therapist to run that through a co-oximetry. Okay? And then the normal carboxyhemoglobin in non-smokers is less than 3%. In smokers can be up to 10%, but anything above that will be abnormal. Okay? And the treatment is really oxygen. By providing oxygen, you remove the carboxyhemoglobin and replace it with oxygen. So these patients, you gotta have a low threshold to intubate, because oftentimes, if they have smoke inhalation, they're gonna have edema of the airways. So a lot of times, if you think the patient needs to be intubated, that means the patient should have been intubated already. You're going to give FL2 of 100%, okay? You're going to exclude cyanide toxicity, and then you should know that, because you guys are in the front line, seeing patients in the ICU in the middle of the night. When are you going to refer these patients to Jewish for hyperbaric oxygen? So if the carbon monoxide level is more than 25%, you're going to do that. If it is more than 20% in pregnant patients, if the patient is altered, loss of consciousness, if there is a severe metabolic acidosis with a pH less than 7.1, and if there is evidence of end-organ ischemia. So those patients need to be transferred for hyperbaric oxygen therapy, which is available at Jewish. I believe it's not available here. So methemoglobinemia is the next topic. So definition of methemoglobin, it's a hemoglobin in which the ferrous iron of heme is oxidized to ferric state. So the ferric heme is unable to reversibly bind oxygen. So there are two pathways for reduction of methemoglobin back to hemoglobin. One is dependent on the cytochrome B5 reductase, and another one is dependent on G6PD. So this one is the most common, the cytochrome B5 reductase. That's how the body will reduce methemoglobin back to hemoglobin. Now, you can have congenital methemoglobinemia if you have a problem of this enzyme, if you have a deficiency of this enzyme. But you can also have acquired methemoglobinemia. So that happens. I've seen cases like that in the ICU. Okay, you just need to be aware. If you don't think of it, you're never going to diagnose those things. So medications, dapsone, topical anesthetic agents, inhaled nitric oxide, and chemicals, aniline. So the symptoms are going to be cyanosis, symptoms of hypoxia, abnormal coloration of the blood, and a lot of times the pulse ox will be decreased, but then you get a blood gas and the PO2 is going to be normal. So that is a huge tip for this condition. And then the patient needs to, I know of cases of patients who are in the OR undergoing, for instance, a cardiotoxic surgery, and the oxygen saturation was low. Nobody knew what was going on until someone thought about that. Okay, so again, you're gonna need to run the blood into a co-oximeter. Get a blood gas, ask to do a co-oximetry, and then you're gonna get this diagnosis. Okay. So if the patient is symptomatic or if methemoglobin level is more than 20%, the treatment is methylene blue. You can also give ascorbic acid, but the main treatment is methylene blue. Hypothermia is the last topic for today. So hypothermia is defined as a core temperature less than 35. So ideally a temperature from esophageal probe. So mild hypothermia is defined as a core temperature between 32 and 35, moderate between 25 and 32, and severe less than 28. So the symptoms are going to be tachypnea, tachycardia, shivering. As things progress, you're going to have bradycardia, hypoventilation, hyperreflexia, altered mental status, pulmonary edema, and then you can pretty much look like you're brain dead with areflexia, loss of corneal and oculocephalic reflexes, and then you can develop a systole. So those are the EKG abnormalities that you can develop, and this is just interesting that you can have the J wave, J point, also called Osborne wave. So the treatment depends on the severity of the hypothermia. So if you have mild hypothermia, pretty much all you're going to do is just passive external real warming blanket, other types of insulation. Moderate hypothermia, then you're going to start using active external real warming, like warm blanket, radiant heat, forced warm air. It's very important, this is very important, to real warm the trunk before the extremities. Okay, otherwise you're going to cause a vasodilation. And then severe hypothermia, then you're going to do invasive techniques. So probably require some expertise here. Warmed IV isotonic crystalloid, warmed pleural lavage, ECMO cardiopulmonary bypass. It's very important in patients with hypothermia to rule out infection, rule out sepsis, rule out hypothyroidism, and so on and so forth. That's it for today, guys. Thank you.